At the ASCO 2012 meeting in Chicago, key trials highlighted the effectiveness of several potent androgen receptor inhibitors in the treatment of castration-resistant prostate cancer. Dr. Charles Ryan presented the results of a study on abiraterone and prednisone in chemotherapy-naive patients. He discussed the strong overall survival trend that led to the early unblinding of that study with Dr. Walter Stadler.
So it's fascinating, certainly to me, that coming from an institution that identified the androgen receptor as the critical target for prostate cancer almost a half century ago, that now, 50 years later, we're still trying to learn some things about this target, learn some things about this disease, and trying to learn how to target it most effectively.
Any oncologist who treats prostate cancer is probably sensitive to the fact that there are a lot of patients out there who do not get chemotherapy, and another large proportion of patients who have not yet had chemotherapy. And so the idea behind the current study was to test the efficacy of abiraterone in those patients who have not had chemotherapy, and also those patients who have not developed painful symptoms from their disease. So the trial assessed abiraterone at its standard dose in combination with prednisone compared to prednisone plus placebo in these patients, and it demonstrated a very significant delay in progression, in disease progression as measured by bone scan. The radiographic progression-free survival in the placebo arm was 8.3 months and has not yet been reached in the abiraterone arm, but it's going to be greater than 16 months. Overall survival showed a very strong trend, and those 2 points of data, which are the co-primary endpoints of the study, compelled the Independent Data Monitoring Committee to recommend that the study be unblinded. In addition to those co-primary endpoints, which are very compelling, are the data that look at issues related to time to progression of the disease, to pain, time to the need for opiates to control that pain, time to chemotherapy, etc., all of which favored abiraterone, which indicates that when patients are taking abiraterone in this asymptomatic, if you will, earlier clinical state, that they are maintaining quality of life, maintaining a pain-free existence, not getting other treatments, etc. So we think that, taken in aggregate, those data show that there's a very compelling case for clinical benefit in this group of patients. For my own part, as a medical oncologist, I will say that ever since the beginning of studying abiraterone, we felt that the natural place for this drug to be utilized is in the patients that were addressed in the study that I presented. And the post-chemotherapy population is one that represented those in need of those with the greatest unmet medical need previously, and those with the worst prognosis. But the greatest potential benefit of the drug, I believe, could come in the earlier use of it.
In their interview, Dr. Stadler and Dr. Ryan discussed other notable studies of androgen receptor pathway inhibitors at ASCO 2012, including new findings on enzalutamide, TAX 700, and intermittent versus continuous androgen ablation.
That study is in enzalutamide versus placebo in patients with chemotherapy refractory disease. A couple of quick points in there. One is that it's a very different population than what we're talking about with our abiraterone study currently. But what they showed was that upon the secondary analyses, they looked at quality of life, they looked at functional well-being, and many parameters that we all want to see in clinical trials. And they generally showed that patients who received enzalutamide had an improvement in their quality of life or a more maintained quality of life and functional well-being than those who were taking placebo. Now, one interesting fact is that in that study, the patients were taking a true placebo. In the abiraterone studies, all of the patients were taking prednisone, and that was the control arm. Prednisone, as you know, is an active drug against prostate cancer. About a quarter of patients will respond to it. And so the differences in the quality of life outcomes as they emerge between the abiraterone studies and the enzalutamide studies may look like there's a greater difference with enzalutamide, but that's because they're comparing to a true placebo, and we would be the abiraterone studies would be comparing to a prednisone control. That's one point. Another point that's actually interesting and emerged at this meeting, and there's been a lot of talk about it, is that in the enzalutamide phase 3 study, about 30% of patients were taking steroids. And I presented data to show that in the abiraterone studies, steroids are an active control and actually may confer some clinical benefit to patients. So one of the things that's going to be really interesting to follow is what is the differential outcome of patients who took enzalutamide or placebo in those studies and also took a prednisone, because they would be taking really 2 drugs as opposed to 1, and one wonders, we don't know, one wonders if that may actually confound those results. And so Johann de Bono, when he gave that presentation, said we are analyzing those data to find out what the role of prednisone, good or bad, is. He made a suggestion that there's actually a potential negative aspect to prednisone. Our data would suggest that there's probably some positive aspects to prednisone therapy.
And were there other androgen receptor pathway targeted agents presented at this meeting that are of interest to you, that you found interesting?
Yeah, sure. So there's another CYP17 inhibitor called TAK-700, and that is showing some promise. It looks very similar to abiraterone, and there are a couple of different directions that are being taken with that agent. In addition to being tested in metastatic disease, they're also testing it in non-metastatic castration-resistant prostate cancer. There are also studies presented also with abiraterone, but looking at it in the neoadjuvant setting, looking at its use in earlier stage disease. Those were studies that are very intriguing, and the data are from some very good groups and really very exciting, but I'm not sure it's ready to be incorporated into our thinking in terms of standard of care yet.
So going back perhaps to what we've done in the past with LHRH agonists in prostate cancer, which was some of the original androgen ablation, there's also data presented here at this meeting of intermittent versus continuous androgen ablation.
Right.
And tell us a little bit about that data and how you might interpret it.
Sure. So this is a long-standing question about the potential clinical quality of life and clinical outcomes benefits of stopping androgen deprivation periodically in patients with this disease. And there have been a series of many trials over the years that have suggested that periodic stopping of androgen deprivation therapy not only confers quality of life benefits, but it is not inferior to continuous androgen deprivation therapy. So the study that Dr. Hussain from the University of Michigan presented yesterday at the plenary session looked at a randomized trial of patients with metastatic untreated prostate cancer who were treated with androgen deprivation therapy continuously, or androgen deprivation therapy that was stopped after a period of several months and restarted when their PSA rose to 20. And that study was, I forget the actual number, but it was designed to look at it as a non-inferiority approach. And so a positive study here would have shown that intermittent androgen deprivation therapy was not inferior to continuous androgen deprivation therapy. And it turned out to be a negative study, suggesting that, and this is where there's a lot of double negatives, suggesting that intermittent androgen deprivation therapy was not inferior. And so it didn't prove that it was equivalent, and it actually maybe suggested that it was slightly worse, that some of the outcomes were worse. I think that these data are going to be very controversial. I think that it's not clear to me that the standard of care is going to be impacted substantially by these data. I'm going to be very intrigued to see the full manuscript that come out from this and how I interpret it. A couple of caveats with this is these were patients with metastatic untreated disease. And at our center, we have always been treating these patients with continuous androgen deprivation therapy, and only on rare occasions do we go to intermittent. Another area where we use hormonal therapy, of course, is in the rising PSA patient who has non-metastatic disease, has already had treatment with radiation or surgery. And for those patients, there's even less data on this comparison, and I think there's also a lower burden of disease. And so in that situation, we continue to be comfortable treating patients on an intermittent basis.